Tuesday? I think it's Tuesday. So I decided when I was going to talk about assessments to like put on like scrubs. So this is like the Nurse Katie experience here. I'm going to do an assessment on John, and then I'm just going to go through kind of my routine when I meet my patients and go through it all so you can kind of see it. So not only do I have my stethoscope, I've got my badge on, and I've got a full scrub outfit on for y'all here, okay? So let me just introduce my patients for this evening. This is Chad. Chad Woods, say hello. He's really excited about being here, guys.
Nope, not even a little bit.
Oh,
I'm joking. I'm joking.
All right, thank you, Chad, for being here. And then we have John Cleaver here. Sorry for the posture, but
Yeah, that is a little weird.
You're a little
like
spread eagle. Well, John,
Very modest.
as you can tell, John, and as you may have known from my post, John tore his Achilles. So he had surgery Friday. That's his foot all splinted up. So we'll pretend that's his reason why he isn't. So I'm going to assess John first, and then we'll see if you guys have any questions or anything specific, and then I will assess Chadley. So, all right, Chadley, you're up. Well, you're up to hold the camera thing.
You want to hold it this way or sideways?
No, that was perfect.
All right.
So, okay. We also have Mac here that's going to stand in the way to prevent me from really getting to him. That's okay. No, it's okay. We can leave him here. So when I go into a room, I have my stethoscope and I have my pen light. Does it work? Yeah. So that's what I like to have with me to make sure I have those two things. I also have my scrub sheets in my scrub pocket. Heather or John or whoever is doing, the comments, can you put a link to scrub sheets? So these are some awesome little like tools and tricks. Like this has, if you forget your assessment stuff, it has a little reminder here, and then you could write on it and erase it. EKG and heart sounds, and also lung sounds. Okay. So let's say John's admitted for this injury. He did it outpatient, so realistically he wouldn't be unless there was like severe complications or something. But I'm just gonna pretend like I'm walking in the room and I've looked at his charting or his patient chart and everything. But let's just say he's like kind of an average med-surg patient. Okay. So I walk in the room. I notice if he notices. I notice if you notice me. You noticing me? Noticing me?
I put you on notice, and I noticed you too.
Yes. That's why we're married. Okay. Actually, Mac,
get up.
Mac, get up. Come here.
Good boy.
Stage left. Oh, thank you. He looks so mad. Okay. Hi, Mr. Cleaver. Or do you prefer to be called John or Mr. Cleaver?
Mr. Cleaver, man.
Hi, Mr. Cleaver. My name is Katie. I'm going to take care of you today. How are you feeling right now?
Feel okay?
Are you having any pain?
A little bit.
Where is this pain?
It's in my foot.
Great. What would you, on a scale of 0 to 10, 0 being no pain, 10 being the worst pain in the world and could not get worse, what would you rate it as?
3.
Do you need any pain medication?
I just took some.
Okay, we'll be good. Okay. Can you tell me your name, the month, and why you're in the hospital right now?
My name's John Cleaver. The month is September 2016. I'm in the hospital for tearing my Achilles.
Okay. All right, I'm going to take off your hat here. Oh, I love that hair. That looks great. Oh,
I would
not do that.
I'm uncomfortable.
I would not do that. Don't do that.
I do it again.
All right, John, can you look at me? Look right at my nose. I'm going to shine a light in your eyes, okay? There we go. Okay, good. All right, and side note, my tendency is to want to do a full neuro thing, but if he is a med-surg patient, no neuro deficits, I'm not going to do all the nitty-gritty little neuro stuff. So I'm not going to get specific on neuro and I might do that when I assess Chad, but not with John here. Okay, can you squeeze my hands? Can you push me? Push me away from you. Good. Can you pull me towards you? Good, good. I am going to listen to your heart and your lungs, okay? So can you lean forward for me? Yeah. You okay? Comfortable? Mm-hmm. Good deep breaths. Last one. Good. Go ahead and lay back. And listen to your heart here. Normal breaths. Okay. All right, listen to your bowels here. When was the last time you had a bowel movement? Sorry, that's what you guys. You don't have to answer.
Sometime in the last few days.
I just did that instinctively. I forgot that. Sorry.
Should I be reading any of these questions?
Not yet. Let me finish this.
All right.
So you're listening in all four quadrants. Okay. So usually when I'm listening to their bowels is when I ask them when their last bowel movement was, if they remember it. And something that's helpful too when you're listening to lung sounds is you want to listen to one side and then go to the other side and then go down and then go to the other so you can compare each side, okay? So you're not going down the right lung and down the left lung, but you're going, okay, how does the top sound comparatively the middle, the bottom lobes? And then I'm going to check his pulses here. Okay. Do you have any numbness or tingling?
A little bit.
A little bit. Where is it?
On my foot.
He's acting like I'm crazy, but I got to ask him. Don't assume. You never want to assume.
No, I didn't know if I was supposed to answer.
Oh.
Okay.
Oh, yeah, sorry.
Yeah,
So,
my foot.
can you wiggle your toes for me? How about these toes? Push down on my hand like you're pushing on the gas. Good. Can you pull it up towards your nose? Good, good. Can you pick it up off the bed? Good. Go ahead and set it down. And then you can wiggle here. Can you feel me touching?
Yeah, it feels funny though.
Okay. And if it was inpatient and I could, ideally you want to like be able to palpate the pulses, but he's got the splint on. I can't get his pulses, but I'll check the pulses here, his pedal pulses. Good. And I'll do some cap refill. That looks good. I always touch the feet last. Something just, think about going head to toe. And if you have your gloves on and you're touching their feet, just be conscious, like if you touch their feet and then you go up and touch, it's like don't touch their feet and then go up and touch, So usually I work my way down, and when I'm done here, no matter what, I'm taking off my gloves and switching because I touch their feet, And then while I'm doing this, I'm checking their skin. I'm not going to check his skin, but you have to do a full skin assessment. And even on totally fine patients, you really want to make sure that you see...
How fine?
John Cleaver fine. Back here, John. We gotta... so you want to make sure you're looking at all their skin and use your nursing judgment. Because let's say he had a wound or something with a dressing on it. I am going to wait to assess that wound until I have time to actually change the dressing. So if it's like a BID dressing change, a daily dressing change, or whatever, I'm not going to assess him now, rip off the dressing, assess the wound, put a new dressing on or put that one back on, and then come back and then do the dressing. It's like you want to make sure that you're kind of consolidating that stuff. So, and I would do that, like, let's say I had a patient that was, like, morbidly obese or really large and they weren't able to move themselves. I'll do as much of the assessment that I can independently, and then when I have a CNA or someone to help me turn, I'll consolidate that with their rounding. So, like, typically, like, the CNA would be rounding and doing vitals when I'm doing my assessments. So I would wait until I could work with them to assess the back side of them, so I'm not making my patient kind of, you know, okay, I'm turning you all the way over just to turn you back and just to have the CNA come in 30 minutes and do that anyway. So as much as you can kind of consolidate, I know when I started I thought, hey, I have to do everything all at once, but you know, think about the patient's needs and what's going to be most, I guess, just make most sense. You know, you don't have to do everything right that second. And chart so it all looks perfect in your charting. You know, do the best you can to get as much done, you know, and cluster things that make sense, if that makes sense. So were there questions that during that came through?
Yeah.
All right, let me switch and I'll take a look. 10 comments, yeah. All right. Check for the, yep. Let's see. Oh, what's my husband watching? Y'all. He is always, when in doubt.
2003.
When in doubt, always basketball.
Lakers. Kevin Garnett just retired.
Always. Oh, do you guys like my brain here? My little brain. Okay, so I don't always listen over the clothing. It kind of depends. I didn't really want to pull his shirt up or anything, but if you have a gown, a patient's gown, it's much easier to kind of get in the back of it and listen to it. But I have found, honestly, that listening over the clothing, unless it's someone that has abnormal sounds, it doesn't make too big of a difference. So sometimes I do that, sometimes I don't. Yeah, I mean, I'm not going to take his clothes off. So his numbness and tingling. So I'm gonna make sure, hey, is that a new thing or is that a consistent thing? And I guess I didn't address that I know he's been having the numbness and tingling in his leg, and it's related to his surgery. Now, if this is new numbness and tingling, and it's something too to think about, does the patient have a history of something where they're gonna have numbness and tingling? Because I've had this before. I've asked patients, done that whole thing, hey, do you have numbness and tingling? Yes. And I'm like, oh my gosh, what's the deal with the numbness and tingling? And then I look at their chart, or I ask them, how long have you been having that? I'm like, 30 years or whatever. Diabetic neuropathy makes people have a lot of numbness and tingling. So you want to make sure that it is, if you're going to intervene, it's got to be a unexpected finding, I guess. So, you know, I know he's got the numbness and tingling related to his surgery. Has it changed? Is it new? So if they say, you know, yeah, I'm having numbness and tingling. Well, is it different than what you normally have? Tell me about how it's differing from your normal diabetic neuropathy, numbness and tingling. You know what I mean? Oh man, I'm kind of, Oh, nice. Yeah, I love these bad drills. This is Betty the Brain. So do you do a full assessment on patients daily if you've had them multiple times in a row? Yeah, you kind of need to do that. But it kind of makes you go through it kind of quicker, but, you know, still, even if, so typically on the floor, and typically, I don't want to say, you know, because hospitals differ, but typically on the floor, you do one assessment a shift. If you're working in step down, it might be a little more frequently. In ICU, it's typically at least every 4 hours, and if something changes, and then we do neuro assessments every 2 hours. But even if I've had the patient every day for the last 4 days, I still go through the whole thing, still look at their skin, still ask the questions. Oh, I wanted to make sure I said this too. I'm going to set this on here. No, it's okay. I'll have it right here. Yeah, I got it. Because then I can kind of see the comments. Something I always do, no matter how silly it sounds, is I always ask the orientation questions. I used to think, hey, you know, he seems totally fine. Why do I have to ask him his name and da-da-da-da-da, and can you tell me your name? You just told me it, you know. It's really important to get in that systematic habit of doing that, because sometimes people can really seem with it and they're not. One time I had a guy walked in and he acted just like John did. He wasn't near as handsome, though. Keep that in mind. Not near as handsome as John Kleber, but I walked in and I did looked just fine, and he said, I said, can you tell me your name? He told me his name. What year is it? And he was like, 1984. And I was like, is 2014. What is it? So, and I realized even though things seemed fine, he was confused. And I would not have known that if I did not ask the specific questions. And even if it's someone I'm pretty sure like they're totally fine, I always say, now just humor me. I gotta ask my questions. I gotta ask my silly questions, something like that. So it's like they understand that, hey, this is part of it. This is just gonna be what happens. Sorry, yeah. Having trouble listening to crackles. Any tips? You know what I think is really helpful? Make sure you have a good stethoscope. Make sure, what I've done before is listen to sample lung sounds on YouTube. That can be really helpful. If you are a student, or maybe you can ask if you can follow around a respiratory therapist. They listen to lung sounds all day, every day. So they're a wonderful, wonderful resource. So I recommend that too. If you're a newer nurse, you can always ask the respiratory therapist about that as well, because you might have a little more frequent access to them. So, yeah, sorry about the skin. Listen on the skin, and typically in patient thing, you got a gown that you can easily open and stuff, but I'm not going to do that for John. Okay. We were taught to actually feel and put our hands on our patients and wear gloves if, oh, that's interesting. That's interesting. I've never heard, and I'm sorry, I didn't tell people what I'm reading. Ariana commented, do you always wear gloves when doing assessments? I personally do. My reasoning for that is, though, you never know when you're going to run into a bodily fluid. Sorry. I know that's gross. But you never know if someone's got a wound somewhere, maybe under their gown, or somewhere where you don't see it, and all of a sudden, hey, your hand is in pus or whatever, or sweat, and a lot of patients are sweaty in the hospital. So, while that makes theoretical sense to, not wear gloves because, you can actually, but I don't know, I find that if I make the contact with shaking their hand at the beginning, that provides that I'm connecting with you, and then I throw on my gloves and do my assessment. That's kind of what I do, I think. But if you're told to do something different in nursing school, I don't want you to have to, not do that. But that's just what I do. Okay, are there any specific med-surg assessments to keep in mind for med-surg floors, like surgery, wound assessment? Yeah, so that's like a super, super, super general assessment. But you got to think, if your patient has a specific thing going on, you're going to focus on that a little bit more. So, like if they had a surgery, you're going to make sure you're looking at that surgical site. You're assessing that surgical site. He has a dressing on covering it up, so I can't, and it's a dressing that has to stay in place. You want to be able to visualize the wound every shift, but sometimes they have a dressing in place where you can't see it, and you have orders not to take that dressing off. So you chart unable to visualize, the dressing has no drainage on it visible or whatever, and you chart what you see, but if you can take that dressing off, you should. And that kind of goes back to my point too, is you also want to minimize removing and replacing dressings. Like you only want to do that if the frequency that is ordered, or unless your dressings are getting saturated, because pulling off tape and putting tape on is really irritating to the skin, even if they have that paper tape. You want to minimize that. So, maybe patients have wound vacs, they have whatever kinds of dressings. So if you don't have time to, and I remember working on that vascular floor where we had a lot of patients that would have packing, wet to dry dressings, wound vacs, tons of stuff. And it's like, what I would typically do is go assess all my patients first, medicate everybody first, and then go back and do dressing changes, because sometimes I would get in there and it would take a heck of a lot longer than I thought it would. There was one time that I was doing a patient's fasciotomy incision. She had bilateral fasciotomy incisions from Compartment Syndrome, and it went, oh my God, I was in that room for 45 minutes or an hour just trying to pack these two wounds and did not anticipate that at all. So those are kind of my hints on that. And then obviously a neuro assessment. a little different than that. If I'm on a stroke floor, you know, it depends if you need to do a stroke scale, and that kind of stuff. So I kind of wanted to stay focused on just general med-surg right now. Okay, the website for scrub sheets goes to Amazon and they are not available anyway. So, I know John said that they sold out and they had to reorder and stuff. So I know that they are going to be available soon, and maybe someone already addressed that. You felt both, I almost blocked somebody and didn't mean to. Someone addressed that. Felt both radial pulses at the same time. I guess I don't have a reasoning why. It's just kind of easier. And sometimes I'll assess, I have my hands there together at the same time, and sometimes I'll push down one so I can make sure I feel it, and then pick my finger up and then push down the other. But you can't really exactly see that because I have my hands there just simultaneously. I think everything is in metric on there, Serena. Tips for finding pedal pulses in large patients. Okay, so I worked on a vascular floor, so I have experience finding pedal pulses. Tricks: do not push down too hard. You don't want to push down too hard because you're going to occlude the vein and not going to be able to feel it as easily. So touch lightly and just kind of increase pressure slightly as you're looking. So trying to think. So when I'm doing the not dorsalis pedis, the posterior tib pulse, I touch their ankle and John, do you have your sock on?
Yeah.
Or no, you don't. No, I want it not on. Hold on. No, your foot. I sound like you said cell phone, but I said sock.
That's what I thought.
Can I see? Can you put your foot right here? So I look for the oh my god, the ankle, and then I just kind of go down right here, and usually you can find that pulse right there. And then the dorsalis pedis is typically kind of right above, like right here, and touch real light. Don't push down. You can't really see. I've barely got my hand on there, and then I can feel it. But honestly, it takes a lot of practice. And on my vascular floor, we used a lot of Dopplers and stuff, which is helpful because I'd find it with the Doppler and then try to palpate it. But always use that as a backup. If you can't palpate it, get the Doppler and use that. And sometimes, honestly, even some experienced nurses would have trouble finding a pedal pulse, and we just have to ask each other to help. And, hey, I can't find this pulse. Have other people try and find the pulse before you call the physician. And use kind of your clinical judgment. Okay, is their foot warm? What's their cap refill? Because likely if you can't find a pulse but their cap refill's good, they're not having numbness and tingling, their foot feels warm, chances are it's a matter of not finding the pulse, that instead of it not being there, if that makes sense. The Braden Scale. Sitting wound care. Oh my gosh, we use that all the time. Seymour. Well, honestly, the Braden Scale, gosh, I don't know if I have any more helpful tips to really understand it. I do know we use it every shift. I am required to chart a Braden Scale every shift, so it is important to know. Honestly, gosh, I can't, because I go through the pre-selected, the thing that gives me the options, and then I do the numbers. I don't have it memorized, so I don't know if I have anything. If someone else or Heather has anything, 'cause Heather's a wound nurse, if you have anything helpful about the Braden Scale, but I do know that I use it every shift and it's helpful. And if it's a certain number, then it tags me or reminds me to put in skin care care plan. Had a patient with Down syndrome last week. Adult failure to thrive. Nonverbal, a lot of involuntary movements going on. Mom said that was normal. How did you check orientation? Patient may be oriented, but how can I assess that if she's nonverbal? Ugh, that is challenging. It's helpful if you have a family member there to tell you, hey, is this baseline? we want to know what their baseline is and how are we going to know if it changes, right? Because, you know, the theoretical baseline is alert and oriented ×4. But yeah, you do have those nonverbal patients. So mom is a critical aspect of the assessment. And you have to, and I think it would be beneficial to establish a specific way to do that with that patient that works. Gosh, without knowing specifics about the patient, it would be really hard to tell you what to do. Sorry, I don't know what else I could put there. Failure to thrive. Let me just think about that for a second. Yeah, I think I would work with mom and try to develop ways to assess if they were, because there are patients, you won't be able to ask orientation questions, but what's their routine? What do they normally do in the morning and at the beginning, or, you know, in the evening? And how can we tell if things are different? And I don't know, I think you would really have to work with mom to figure that out. Do you do a full assessment each time your shift starts? I was told to do. So a full assessment, that's essentially what I just did. I do that when I worked on the floor. I would do a full assessment at the beginning of every shift on every patient, and then if I got a new admission or switched patients with someone, I would do a full assessment and chart it. And then I would only do another full assessment if something happened, like they coded or they started to deteriorate and I had to call the physician and we had to do something, or, you know, that kind of thing. So that's how and it's really just like what I was doing. That's the basic full patient assessment. You hit all the body systems, and you check their skin. I also, if he's on telemetry, I'm looking at his tele. Oh, and something I didn't include in there, but it's really important, but is the vital signs. So normally as the nurse, I'm doing the vital signs, the CNA is going by, as the nurse, I'm doing the assessment, and the CNA would go around and do the vital signs on the unit I was on. So I could compare that to what's going on with the patient, and it would be helpful. Typically the CNAs would be finishing their vitals when I'm doing my assessment, so that when I'm giving them medications, I can look at a latest blood pressure, latest heart rate. But at the beginning of the shift, if they're on telemetry monitoring, I'm looking at the tele strip and interpreting the strip and charting it so that I can see if it's different than the last nurse, because sometimes changes occur between nurses looking at it, between telemetry monitors looking at it. So it's really important to do that, and I like to do that before I go into the room. How often do you reassess pain if they give it a 0 in your initial shift? So I ask about pain, especially if it's a patient that had a pain. I didn't even notice you can see like basketball in the back. I reassess pain every time I round. I don't know what it says per policy at our hospital or what they teach you in school, but every time I go in the room, I'm asking about pain. That's because I want to stay on top of it. Because if you had a patient that had a relatively painful surgery and they're saying, I'm okay in pain, and I've had a lot of patients try to be heroes, and they wait until they're in excruciating pain before they ask for a pain medication. Well, that sucks, because if they would have told me an hour before they got to this excruciating pain point, I could have given them an oral pain medication. It probably would have controlled their pain. But now we're past the point of pain control and the patient's losing their mind and in awful pain, and now I probably have to use an IV medication when an hour ago an oral medication could have been sufficient. So that's why I like to be pretty proactive about asking about pain, because I've had that too many times where it's like, oh, now I got to give them 1 milligram or 2 milligrams of morphine just to get them under control, and now they're going to be sleepy, and physical therapy is supposed to be coming by, and blah, 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 and now this day that should have been productive for this patient no longer is because we weren't proactive about their pain. So I ask every time I go in the room, but I don't know, I don't know what policies really say if the patient said they were not in pain. What surgery did John have? He had an Achilles tendon repair. No, that's fine. Back to not telling, I know you said his, however, for students When we would begin, oh yeah, you are, yes. Okay, so this guy's like 3 days post-op, but yeah, if you have someone that has had a surgery like that, you are concerned about compartment syndrome. So what you want to know is this new? And when did it start? How severe is it? Tell me exactly what it feels like. Where exactly on your leg is it? You're palpating pulses, and that's a point where I'm calling the physician if my patient has a new numbness and tingling. Hey, do you want me to pull back the splint so I can assess pulses? I'm looking at the toes, those kinds of things, because they might want to come in and intervene. So it's really important with a patient that has had, like I had patients that had posterior or popliteal femoral bypasses and various bypass grafts in their legs, and this is a really important thing to assess. So you got to have that baseline. Hey, do you have numbness and tingling? Yeah. So when did it start? Oh, I've had it for 30 years. Or, oh, I've had it for about an hour and it's getting worse. And it gets worse when I do blank. It gets better when I do blank. You want to ask a lot of questions about it so you can understand that as much as possible, get as much background as possible before you call the physician. Because if he's had, a little bit of numbness and tingling since surgery, physician has been aware of it, maybe they have it in their notifying if it gets worse or something like that, that's another thing. But if we're having new, worsening, changing issues like that, that's when you want to use your nursing clinical judgment, assess fully, make sure you're communicating and looking at the previous notes, and is this a new thing? For comparison. I just missed the first time. Okay, respiratory assessment. So it kind of depends. So I listen to 6 spots on the posterior, and let me get my Scrubs cheat sheet. So I love this thing because it has the different, it's backwards. Has the different the sounds and where to listen. So I did the posterior, but posterior and anterior. I listened to posterior lung sounds. I really should have listened to anterior as well, but I listened to his heart sounds at the front. But you can hear really, really well on the back. But it also, this has bronchiolo, vesicular, and, I say that wrong, vesicular or whatever. But this also has, not only are you listening to them, what it sounds like, you're also listening to the pattern. And it's also really important, even if the patient's got a breathing tube, even if the patient's got a lot going on, you gotta listen to the back of their lungs. So I encourage you to look at this. We have a respiratory post, but that's just, a little bit of respiratory. So also looking at your O2 sat, that's important, making sure that's within normal range. And if they have oxygen, that it is at the rate that it needs to be through the appropriate device, that it is attached. All that is part of the respiratory assessment other than just the lung sounds. If there's already an X marked on top of a foot, does that mean then previous nurse used a Doppler to mark it? Yes, that's usually what that means. I remember working in that vascular unit, and we did that all the time for patients that had pulses that were really difficult to find. They had poor circulation. We always had patients coming in and out for our grafts, so they had poor circulation. So typically that first nurse, when they would find it with the Doppler, because it would take a while. So just to encourage you guys, like sometimes it takes a while to find those pulses, even if you're experienced. It's not like you just put it right on the skin and hey, I got it. Sometimes it takes a little finding, but they would make an X with a Sharpie so that every nurse isn't screwing around for 20 minutes trying to find this pulse. So that is what that means. And sometimes they'll do that in the OR or right in post-op or something. Alert and oriented ×4. So person, place, time, situation. Do you know so you're in the hospital, do you remember why you're in the hospital? That's a big one because a lot of patients, maybe they had a trauma, maybe they had something that happened that brought them into the hospital and they don't remember that event. So sometimes you want to assess and remember what brought you to the hospital. And I ask that to every single patient, no matter how with it they are. That's kind of like the core of that level of consciousness and, or not level of consciousness, but orientation assessment. Oh, yeah, you got that. Yep, you guys got that. Good job, 100%. Oh, pain every 2 hours, yeah. Play. please discuss pain scale. Oh, I could go on and on about that. You have, so that's kind of the way that you quantify pain in most hospitals is the pain scale, and then you'll have PRN medications ordered based upon the pain scale. So utilize hydrocodone and acetaminophen for a pain scale rated, 3 to 6, and utilize oxycodone and acetaminophen for 7 to 8, and 2 milligrams of IV morphine for 8 to 10, or something like that. So, but the important thing is that you make sure your patient understands what the pain scale is. So frequently, and like I did, I said, hey, I have 0 is no pain, 10 is the worst pain in the world. We want to try to give them some context around what 5, 6, 7, 8, 9 is. So 10 is, I can't communicate. I'm in so much pain, it could not possibly get worse, and I am losing consciousness. Pain. The rest of the scale is kind of like typically, 1 and 2, it's like, okay, it's there, but I can still function, I can still do things. 3 is like, it's there, but it's harder to ignore. It's kind of annoying and frustrating. It's kind of like I stubbed my foot, kind of thing. 4 and 5, we're kind of getting to the point where, hey, maybe pain medication is going to be appropriate, and then so forth and so forth. All right. Ask for the pain scale, and then what kind of you utilize that to see how bad is this? What kind of interventions, are necessary, and you really need to know that for giving pain meds. So hey, I'm going to give him a hydrocodone or a Norco for his pain scale of 7, and I'm going to chart, the pain scale of 7 in his right foot, dull, aching. Medication given, and I'm going to come back and assess within an hour later, hey, now what's your pain scale at? Pain was at a 7 earlier, what is it now? And what does it feel like now? Because you want to see, hey, is what I'm doing to intervene on their pain effective? All right, hold on, let me look at this one from Kevin. What helps you remember? Whoops, see more. Remember to do a head-to-toe assessment for first semester nursing school. Structure, then function. I get pretty much everything on the list, and I'm getting faster, but I want to learn if there are even better, more efficient ways of doing this. I understand all the little parts, the sequencing can do most in one sitting if I look at it, but each body, it's called a head to toe for a reason. You really want to go from head all the way down to the toes, and, you get more systematic, and more, routine with it. Honestly, you get faster at it from just doing it more. Brand new concept first semester of nursing school. So, just keep practicing, keep doing it, and thinking about, hey, if you have a patient that had bowel surgery, if they had a specific, incision or whatever, or maybe this is a patient here with COPD, or maybe this is a patient with a heart attack or a stroke, you're going to be a little bit more detailed in whatever body system that is affected. And then behavioral health assessment's totally different. I'm honestly not sure what their routine assessment is, but it kind of, in real world nursing a little bit, it's kind of really depends on the unit. Like in critical care, when I'm doing a critical care neuro assessment, it is extremely in-depth, but it's not at all necessary to be that in-depth on the stroke floor. Not at all necessary to be in depth like that on the med-surg unit. It's just not necessary, and it's not practical and realistic to go through all of that. So, you really kind of have to look at, it's not like, okay, this is the one way that you learn assessments, and that's the only assessment you're ever going to do. It's going to be really dependent upon not only the patient population on the unit, but also what specifically is affecting that patient. So you really use your nursing judgment. So when you're learning in nursing school, they're kind of doing like, hey, big picture. This is like everything you need to know and pretty in depth. But then when you get out there, you get your routine and you figure out specifically where do I need to be a little bit more detailed and not. I'm losing my breath. Oh my gosh, talking so much. Okay, how did you choose what specialty to start on? Where I got a job. I honestly had a choice of working in a regular med-surg floor and this like cardiac step down, and I took the cardiac step down. It was honestly just where I got a job. Had no idea I would like it as much as I did, and then I got a job in a neuro ICU and absolutely love it. So I didn't really choose, like it wasn't like, oh, what are all the specialties and what do I want to do? It was just kind of like, where can I get a job? Oh boy. how long does it take you to do a full assessment? Depends on what kind of a patient it is. If it's a neuro ICU patient and they are fully awake, it takes me quite a while. If a neuro ICU stroke patient, going through that NIS stroke scale, doing everything, that takes me a while. It takes me maybe 10 minutes. A med-surg patient that is non-complicated or whatever, I mean, I'm probably getting that assessment done in a minute and a half to be like real. Like you just boom, 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 go through it, and you get so fast at it, and you know when to be worried and what to, you know, and you just get so used to it. So it really, really depends on what's going on with the patient and also how much they talk. If the patient is really chatty, it's like, oh, I can't tell you how many times I go to listen to their lung sounds and they keep trying to talk to me. Or I'm listening to their heart sounds, their bowel sounds, they keep trying to talk to me and I have to tell them to be quiet so I can actually hear, because I can't hear anything when they're talking. And it's like, oh my gosh, so it really depends on the amount of questions the patient and their family is asking, and what's going on with the patient specifically. So it can vary widely. So it can go from, and if I'm doing an unconscious neuro exam on an intubated patient that's pretty much, you know, brain dead, that takes like 20 seconds, like honestly, because there's not that much there to assess. So it's such a really wide, you know, variety. Do you feel like you learn more on the job than in school? So I feel like nursing school was very broad and theory-based and big, huge picture-wise, which makes sense. It's really important to have that basis and understanding of the nursing profession and stuff. But I learned a lot on the job because this is the specific stuff I need to know for the cardiac step-down unit. I need to know about external pacing wires, and I need to know about AFib with RVR and how do I do that, and how do I assess a cardiac patient that just had open heart surgery, and how do I do that kind of stuff. And then when I got into the neuro ICU, that was a totally different world, and I felt like I started all over again. So you learn a lot in nursing school, and you learn so much, you know, on the job. Oh, thank you. So my glasses, okay, glasses only bother me when they don't fit right. So I have to make sure they fit right. So have somebody fit your glasses right before you wear them to work, and then they're fine. Because my eyes get really dry in contacts. L&D, next week, can you go over the assessment for a neonate? No, I cannot, because I have no idea how you do that. I haven't assessed a baby since nursing school, OB clinicals 7 years ago. I cannot answer that question, and I am really, really sorry. When you check your A-line, A-lines, what's the purpose of doing that? Do we measure or compare it to the last shift's numbers, or are we looking at any trends? Okay, so A-lines, and it's kind of hard to do it without like having one right here. So arterial line, it is a line that's going right into somebody's artery. Most frequently it's in their radial artery, but you can have them femoral. They just don't do those as much because of the risk of infection. So arterial lines is basically this line that goes into somebody's artery that's continually measuring their blood pressure. They're wonderful when they're necessary, but if they're not necessary, we want to get rid of them pretty quickly. Big bleeding risk. Patient hits it wrong, it can come out and spurt blood halfway across the room kind of thing. So what you want to do at the beginning of every shift is you have to make sure that it is zeroed to atmospheric pressure. So you take you turn it off to the patient, and you take the stopcock, or not the cap off, and then you hit 0 on your thing, and it zeroes the line to atmospheric pressure. So, and I honestly don't know all the explanation for why, but it just calibrates it. So, hey, we're all starting at the same spot. And then once it's zeroed, you put your cap back on, you open it to the patient, and you flush it, you can see the waveform. And I want to make sure my waveform is appropriate and accurate, because if I have whip or if it's dampened, that means the numbers that are coming across on my thing are not necessarily accurate. So, I always zero it at the beginning of the shift, check my waveform, and I get a non-invasive blood pressure reading on the same arm that the A-line is in, so that I can compare the two numbers. Because if I'm off more than 10, something's wrong. I want to make sure the tubing's good and everything's okay, but maybe this art line's not good anymore. And so those are the kind of things I'm assessing with the arterial line. Oh, great. I'm just like sweating, guys. I'm sorry. I'm like going through this really fast. Oh, please, not please. Third level nursing student. I'm so excited. NCLEX is nerve-wracking. Go to nursingpracticequestions.com. Got lots of practice questions. Just focus on getting through school, answer practice questions, and just get prepared for it. And then you'll pass it and you won't think about it ever again. Going from ER to PACU, thoughts. You know, I know a lot of people that have gone to the PACU and they really, really like it. Including Chad. You weirdo. Oh my God. So PACU is interesting because you get a little bit of critical care. You get a little bit of ventilators, but then you also get the patients that are doing better and they're coming out of sedation, so they're kind of entertaining. And then you have call, but it's not awful. And so you get your skills kind of sharp, but you don't have these patients for 12 hours. You have them for a shorter amount of time. So honestly, everybody that I've talked to that went to PACU really liked it. I've never met someone that hasn't. Oh, good. I'm so glad. HESI test. Sorry. I have never taken the HESI test. I don't know. I'm sorry. I don't want to say anything I don't know. So, did you take an NCLEX prep class before? Yes. When I was in nursing school, I ended up taking Kaplan, and I enjoyed it when I took it, but that was 6 years ago. So, you know, kind of depends. If you're not an awesome test taker and you need some really specific test taking advice, the book that John always recommends, Test Success, is apparently really good. I've never done that one. We have our nursingpracticequestions.com. That's pretty awesome. So I don't think every person needs to sit down and spend $400 on a class. I really don't. Not everybody needs that. I know some people that said, yeah, sorry, there's some things I don't know. You know, I know some people that just bought a book and studied and that was enough for them, but I was someone that kind of needed to be in class. I don't know if I could do it again. I don't know if I would do that anymore because there's a lot of great online resources now, and I think if you're diligent in taking practice questions and understanding the structure of the exam, then I think that can be enough. You add that with your nursing school knowledge, and I think that might be enough. In response to the question above, not a nurse yet, but has CCT and MAQ. First thing a nurses do is usually check the AON. Oh, thank you. First thing, yeah, you want to make sure. Yeah, oh my gosh, I forgot about. Oh my gosh, I said something about zeroing it, but I didn't talk about leveling it. Yes, you have to level it. If your arterial line is too high or too low, comparatively to where the patient is, then your readings are not going to be accurate. So yes, oh wait, it went away, hold on. Yeah, you want to have that to the height of the patient's, the apex of the patient's heart. That is absolutely essential, and I can't believe I forgot that. Thank you, Ed. I really appreciate that. Any tips on how to learn the material and not just memorizing it? I'm in patho right now, and that's my struggle. Okay, so yeah, because in case people haven't figured out, in nursing school, it's not like other classes where you can just straight memorize something and then perform on the test. The amount of information that you need to know is way too immense to do that. So basically, my recommendation is to really look at the whole body systems and learn the whole concepts. What is not just sentences about heart failure or myocardial infarctions or ischemia or whatever. Understand and be able to communicate the whole concept to somebody else. So read about heart failure. What is heart failure? And try to get your mind around what that is. What is a stroke? What is compartment syndrome? What is a pulmonary embolism, and try to explain that to someone else. That way, if you understand the full concept, you're better able to field questions on the exam and understand it better. Pulse deficit. I was listening to an apical pulse for 1 minute, but I always feel radial pulse. Oh, I can't remember the last time. Honestly, the only time I listen to the apical pulse for a full minute is when I'm pronouncing somebody's dead. I haven't done that in a really long time unless I'm really listening to their heart. So I'll listen. Sorry, that sounds kind of morbid, but listening for a full minute, normally. But I could see why you have to do that in school. But pulse deficit, honestly, I don't know what that is. I forgot. I'm sure I knew in nursing school, but I probably listening to the apical pulse and feeling the radial pulse. But find that radial pulse first, and then listen to the apical pulse. And then, you know, I mean, that would be my only tip. Sorry. I read test success. Was offered Kaplan but didn't do it, and you passed. Wonderful. Yeah, I've known people that thought Kaplan and the classes were not worth it, people that did, people that have done online stuff and thought it was fine. I think it just really depends on your needs. Okay, someone addressing HESI, good. How could a newly passed nurse on a third role like ours could work in one of the hospitals in a foreign country like the United States? What do I need to have that edge to be accepted? Oh man. Well, honestly, if you are able to speak another language, that's really, really helpful fluently. That's really helpful. You know, actually, honestly, having that on a resume is a great thing. You can say, hey, I'm used to working in whatever country, I'm sorry, I don't know what country it is, but with working with less, I know how to make things work, make things happen. I'm very innovative. I can do whatever because I'm used to working with less, you know, and I speak another language, and I'm used to this, and I'm working closely with the healthcare providers, and, you know, I don't know. I think just having that experience can really set you apart. MedSurg pharmacology at the same time. Yeah, that's a tough semester. So NRSNG, we have the MedSurg course, and then we also have the pharmacology, or I guess it's MedMaster course that are really helpful. MedSurg and Pharm, man, that's a tough semester. I recommend again, like I was saying, memorize or understand concepts, don't just memorize them. Figure out a groove, learn how your learning style, learn your professor's teaching style. Just because, you know, you have specific learning styles, professors have specific teaching styles. So I recommend learning them and figuring out how, you know, maybe one's more particular, maybe one's more big picture, one doesn't want, you know, is very specific to the PowerPoints and others are not, you know. Learn your professor's teaching style so that too, when you're taking tests, you know, if you get all hung up on something, maybe you'll miss some points that first few exams, but, you know, once you figure out how you learn and how they teach, I feel like that makes a really good combo. So if you can kind of maximize that, it's really helpful and takes away a little bit of stress. Hold on, I just missed that. And really manage your time, plan out your studying, plan out your test, or I'm sorry, your written papers, plan out that. Plan out as much as you can and structured study time, very focused, specific times. I'm going to study this about MedSurg from this time to this time, and do it. And don't get distracted. Don't have Facebook open. Don't respond to texts, and give yourself 20 minutes of focus and then a 10-minute break, and then 20 minutes of focus and then a break, that kind of stuff. I think that really helps maximize your time and your understanding. And so those are some tips. Oh, good. Someone just said stuff about HESI. I'm glad you did because I don't know anything. Ed's saving my butt again. I love it. If the patient won't cooperate with your nursing management, so when I assume, May, when you say nursing management, like the care I'm giving, or the managers, like my manager. So some patients are a little bit more difficult than others, and you kind of figure out how to deal with them. Sometimes they're not going to do everything you want them to, and you got to kind of pick your battles about what you're going to I don't want to say that. What you're going to encourage and not, I guess. So you kind of pick your battles. You try to anticipate needs, set up specific boundaries, like you're not going to speak to me like that if they're going to be disrespectful. Oh, did you say care? Is that what you meant? Yeah, okay. That's what I kind of thought. Yeah, some don't. And some of them won't because of their mental status or whatever. But like with John, I had him grip my hands. But if my patient's not cooperating, let's say they mentally can't, I'm going to see if there's ways I can kind of gather that information otherwise. So maybe he's not answering my questions, but I can, let's say he's not saying what his name is. I can say, hey, is your name Chad? Is it Lester? Or is it John? And if they can tell me which one it is, okay, I know who he is. Are you at home right now? I do that one all the time. Can you tell me where you are? A lot of my stroke patients. Can you tell me where you are? And then they just look at me. Are you at home? And they look around. No. Are you at church? No. Are you in a hospital? Yeah, I'm in a hospital. What year is it? I don't know. Is it 1952? No. So giving people options. Changing things to yes or no questions. Like I didn't do, let's say he wouldn't cooperate for dorsiplantar flexion. If the patient can get up and walk and I can walk with him, I pretty much know that's, maybe it's not perfect, but I know he can flex those appropriately. So you kind of do little things to see how you can collect that information otherwise. Let me think. But you know what? There are some you're not going to be able to get it. Some you're not going to be able to, they're not going to answer those questions. I've had patients before that were jerks, total jerks to me. And I would try to ask my neuro assessment questions and they were just like, screw you, lady. I'm not answering that. And I'm like, all right, I'm not going to do that. Screw them. So you know what? I'm not gonna get verbally assaulted to assess, you know what I mean? I can tell whatever. So I'm gonna chart what I can chart and get as much out of them as I can, but I'm also not gonna let myself get verbally abused. So I'm just gonna chart what I can, get out of them what I can. But those kinds of things you can kind of get the information you need, I guess. Okay. Okay, what assessment do you do with your different lines? Oh yeah. He didn't have an IV, guys. That's my excuse. So you got to look at, you do your pain assessment, you do your full, head to toe, but then if they have any lines, drains, or anything, you're assessing those entirely. So you're looking at all of the IVs, every single one of them, you're flushing them. You're checking for pain or anything like that, making sure the dressing looks good. You're doing that especially with a central line. You're checking also with the IVs and the central line. When is the central line dressing due? When were the caps changed last? Is the dressing good? Do I need to change it either by time? Because central line dressings are typically changed every 7 days. Even if they look beautiful, you change them every 7 days. IVs, or you don't change the dressing unless it's saturated, or if there's a need to. Typically, a lot of hospitals say 4 days with IVs, but actually the latest research is showing, evidence-based research done by nurses is showing that IVs are good indefinitely unless there's signs of infection. But a lot of hospital policies have not been updated to reflect that. I know Duke did a study on that not too long ago of a ton of IVs, and it showed that. But anyways. So flushing everything, making sure your tubing is in date, making sure your IV bags are good and full, and they're in date. If you're fully catheter, you're making sure that you're looking at the wherever it's going in and making sure that looks okay, and everything's secured. If you have a Dobhoff tube or a feeding tube or a breathing tube, you're looking at where it is. It's the correct size. It's at the correct location. So if it's like a Dobhoff tube, I get in report, Dobhoff tube taped to 78 at the in the left nair. So when I go in, I make sure, because hey, I have had multiple times where in report I get one thing. And in between the last time that nurse assessed and I'm going in, the patient has pulled it out 7 or 8 inches. And that's a lot. If they've pulled it out that much, I got to pull it out and put in a new one. And I got to get a new x-ray or whatever the confirming thing is that you do at your hospital, because patients wiggle those out. And they can take them out just enough where you don't really notice it. Or I've had times too where they say, hey, the ET tube is secured at 23 of the lip. And I go in and I'm like, oh, hey, that's at 26. Or, that's at whatever. And it's like, oh, wait, we need to adjust the ET tube. So you listen in a report, but you always double check. And I always use my pen light, because you can't really see the numbers. So I use my pen light and I double check that what's charted and what I've been told in report matches with what is actually on the patient. As much as you love your nurses that you work with, never ever trust them. When they're telling you information in report, you've got to verify all of that information yourself. So those are things that I look at. If they have a PEG tube, you're looking at the insertion site. If they have a rectal tube, you're looking at the insertion site. If they have a JP drain, you're looking at all of your dressings and making sure they are intact. We talked talked about experience. How much experience do I need to gain for me to be, honestly, someone else asked me this today, and I do not know anything about nurses from other countries working in the U.S. I wish I could speak more on that, but I don't know anything about it. So if there's someone else that knows more about that, please comment and respond. Honestly, I was looking for some resources, really quickly, but I didn't find much. So if anyone has any information about international nurses working in the U.S., that would be helpful. Okay, neuro ICU, do you have much autonomy? I have so much autonomy. The physicians I work with, the nurses I work with, and their support staff trust us, a lot. So I have a ton of autonomy, and I love it. My normal day is I've got 2 neuro ICU patients, and they typically have a stroke or a brain tumor or seizures or what else is there? A subdural or something like that. And a lot of them are on breathing tubes or in some sort of comatose state. Sometimes we have patients that are brain dead and they're organ donors and we're getting them ready for donation. Sometimes we have patients that had a craniotomy and they're pretty stable and they're going out the next day. We work with extraventricular drains, arterial lines, ventilators. What else? I don't do CCRT or CRT, continuous renal replacement therapy. I don't do that on my unit. I know our ICU nurses do. I do not work with intra-aortic balloon pumps. Our cardiac ICU nurses do. So I don't know anything about those. But I really like it. You get really good at neuro assessments and those doctors really trust them, trust your assessments. So it's really cool working together with a neurosurgeon doing a neuro assessment right there and them really saying, hey, what do you think we should do here? And having that and then giving your answer and they really trust you. So it's really cool and I love it. How do I feel about new grads starting in the ICU? It is really hard. It is exhausting. Will challenge you to no end, but it can be done, but you have to be really invested in it. It's not something where you can just go to work and come home. When you go to work, you are getting your butt kicked for 12 hours, and then you need to come home and you need to read about and learn more and bring up more and do homework and stuff to really succeed, because you're not just learning how to be a nurse, you're also learning about critically ill patients. I'm someone that probably would not have been successful going straight out of nursing school into the ICU. I spent 2 years on that step-down unit, and it was really helpful. And I think I learned how to be a nurse, like a practical bedside provider kind of thing. And then when I went into critical care, then I learned how to be a critical care nurse, which is dealing with patients that are, unstable and dying or just died. And, you have a lot to educate about. And it's really hard to be in that role without kind of knowing how to be that, taking care of the stable patients first. But people do it. I've seen people do it and they're amazing at it. It's just not something I could have done. Okay, patient complained I was too busy and was rushing care with them. What should I do in the future when I'm busy again? Okay, that's a good one. We'll do a few more here because I think I've been going for an hour here. Yeah, it can be, you can get kind of focused on tasks, and then before you know it, you're so worried about the tasks and completing things and getting things done that you kind of forget, like, hey, there's this patient here that, I want to, talk to and invest some time in. So I think it's really helpful when you walk into a room, no matter how busy you are. Hey, my name's Katie. How are you? What can I help you with? Kind of just take a breath and slow down. And before you walk out of the room every time, hey, is there anything else I can get you? Because I got the time. And it really kind of, even if you're quickly doing a bunch of stuff and you slow down, you take a little bit of a breath, even if you're 45 minutes or 5 hours behind, that can really make a big difference. And I've noticed too, if I spent 5 more minutes with that patient, they were and gave them kind of the time that they needed, that they were much more chill, much more relaxed, much less needy throughout the shift, because they knew that, hey, when I was in there, I was in there. You know what I mean? And you can kind of, when you're talking to a patient, kind of palpate their emotional needs, I guess. My counselor husband would be proud of me for saying that. But you can tell, hey, does this person really want me in here to talk to them? Or are they really annoyed and they just want me to do whatever I need to do and leave so they can get back on Facebook or whatever? Or does this person really want me to, hey, how are you? Tell me about your son or your family, or, what were you doing when this happened? And, some people just want someone to sit there and talk with them, and just investing that 5-10 minutes in there can kind of make them feel really cared for, and then also save you on call lights later, I guess. Shaken baby syndrome nurse. I don't know what that means. You guys, I'm getting tired. Hold on. How many more? Okay, guys. Gonna do a couple more. When you have a patient that you know is in pain and is being needed to the point of call it every 5 minutes for non-critical needs in the SCQ, no, you can't. But sometimes I've had patients like that where I have to have a little bit of a come to Jesus meeting with them. Like, hey, I will be in here as often as I can be, but I've got other things that I need to do. And when I'm in here, I want to be in here with you and provide the needs and I guess address your needs. But I also have some other patients that are also very sick that I need to take care of as well. So what I do is, hey, I'm coming in. What can I get you? And then I say, hey, I'm going to do this here with you. And I am very focused and in the moment and with them. And then when I'm about to leave, hey, is there anything else I can get you? I'm going to go take care of my other patient. I'm going to make sure they're okay. And then I'm going to be back in about an hour. And I give them a time frame when I'm going to be back. Or the CNA is going to be back in about an hour. I'm going to be back a little bit after that. Put on the call if you need anything. But, I want to be in here. And then if they're really going nuts, it's like, hey, I want to be respectful of your time. And in return for that, I'd like you to be respectful for mine. If I'm in here and you need something, I want to provide that for you. But if I walk out of the room and you hit your call again, I don't feel like you're respecting my time in here with you because you could have asked me that a couple minutes ago. So you got to be really gracious with that kind of stuff because people can get mad. But when someone's hitting the call every 30 seconds, especially the second you walk out of the room, that's not being respectful of you. And I think you as a nurse should command that and you should expect that, I think. But you know what? There's also going to be patients that aren't going to listen to reason. They're not going to listen to that. So you really got to use your judgment. Already on morphine every 2 hours. Oh, well, you know what though? Honestly, some patients do need something like that for anxiety. You know what I would do? I would point blank ask that patient, are you anxious? Ask them, are you anxious? And it's not a bad question to ask. Hey, I noticed you're on the call light a whole bunch. Are you feeling anxious right now? Do you have anxiety at home? Maybe, is there anything that we can talk to the doctor about to help with this anxiety or something like that? Just talk straight up, ask it. Like, if they're anxious and they need Ativan or if they need a little something because whatever happened was so whatever, ask and see if that is a need and if it needs to be addressed. I've done that before. I've done that many times. Hey, you seem kind of anxious. Do you feel anxious right now? Oh, yeah, I'm glad you said that. Like, I feel really, I just cannot calm down. And then it's like, okay, have you ever struggled with this before? And then I go talk to the doctor and the doctor's like, yeah, maybe if we give them a little bit of, maybe a low dose Xanax when they're feeling like this, and maybe we can prevent a panic attack. Some people have those when they're in critical care, when they're in the hospital and they're having these huge, massive things happen in their life and they need something to help them calm down. Because that's, especially if they've got really legit physiological issues going on, you don't want anxiety taking over and adding a whole bunch of additional stress on because you can make the problem a lot worse. But, anxiety isn't something that the physician that's in there for 30 seconds or 10 minutes or whatever is going to notice. That's something that you as a nurse who's been there for 6 hours and you're noticing this pattern, that's something that you're going to pick up on and have to communicate to the physician. Very rarely are patients going to say, hey doc, I'm feeling anxious. A lot of times you have to be an advocate and use your clinical judgment to see if that's going on. Ask the patient and then advocate for them to the physician. How often are you live? We do live on NRSNG weekly. I'm every couple weeks or month or something like that. We kind of switch off. Okay, cool, thanks. Great. Here's about ABGs and electrolytes. We have a couple cheat sheets for that stuff. We can talk about, I think Susan would do a great job. Susan is great with ABGs. Feedback on dementia and Alzheimer's. That might be its own video. I don't know if I could really explain that right now. Oh, I hope this was helpful. Let me see. Nursing school. Oh, good. I'm glad this helps. Pac-Man on TV. Yes. Okay. Gut was anxiety in addition to the pain. Yep. Okay, guys. I think I'm going to sign off. Been on for a little over an hour. I'm getting a little tired. So, I'm going to go through the comments of the video tomorrow. So if you guys have any more questions and stuff, I'll go through and see if I can answer them. But thank you guys for tuning in. Thank you to John. Thank you. Chadley, thank you. Have a good night. And then Mac, hold on, you guys got to see Mac before. Tosh already went to bed. All right, guys. Mac says bye. All right. Have a good night, guys.